his lecture on transarterial intervention in oncology. I request Dr. Rozil Gandhi to give insight about this lecture. Dr. Rozil Gandhi, he did his fellowship in Interventional Radiology at Tata Memorial Hospital, Mumbai. He did a fellowship in liver and thyroid radiofrequency ablation from South Korea. Also had fellowship in Interventional Radiology and aortic neurointervention from Denmark. He has 8 years completed of interventional radiology practice in Ahmedabad with more than 10,000 therapeutic intervention. He has special interest in GI and peripheral intervention. Welcome, Dr. Rozil Gandhi.
Good morning, everybody. I am thankful to the organizing committee and especially Paresh for inviting me, and especially in front of Surat sir, where I trained in Tata. I'll be talking about vascular interventions in oncology. So how an intervention radiologist can help in oncology practice apart from doing biopsies. So we'll go case by case and I will show more or less every indication. Vascular interventions in oncology is divided into two, whether it is embolization or stenting. Starting with bleeds, we cover head to toe. Head and neck tumor bleeds, bronchial artery embolization for hemoptysis, GI bleeds in malignancies. Very important, chemoembolization as a palliative treatment for HCC, hepatocellular carcinoma, when the patient is HCC is non-resectable. In chemo-refractory liver mets of colon, chemoembolization is done. Also in renal tumors, embolization is done as a palliative treatment and also for stopping hematuria. TARE, transarterial radioembolization for advanced malignancies with portal vein thrombosis. Uterine artery embolization for pervaginal bleeds in advanced malignancies. Aortic bleeds sometime when the malignancy is invading the aorta, and very important role of preoperative embolization in curative patients where the intent is curative, like juvenile nasopharyngeal angiofibroma and bone malignancies. Preoperative embolization in vascular tumors has a very good role. Very important, post-surgery bleeds. There are cases where post-Whipple's, the hepatic artery or the GDA blowout is seen, and we have to manage it endovascularly. Post-gastrojejunostomy and or any post-surgery bleeds, IR has a big role. Malignancy is thrombogenic. We see DVTs and vascular thrombosis in case of malignancy. So thrombolysis also plays an important part for better quality of life for the patients. Starting with cases, I'll show each and every indication. This is a 65-year-old male, diabetic, presented for anal fissure treatment. Ultrasound showed a lesion in the segment 6 of liver, right lobe, with high AFP. So with serum alpha-fetoprotein more than 400, it is diagnostic of hepatocellular carcinoma with a CT, additional CT or an MR imaging. So CT showed an arterial enhancing lesion in the right lobe, 6 by 5 centimeter with portal vein segmental thrombosis. So this was a palliative patient and taken for TACE. This is angiographic finding, celiac artery, and the arrow shows a hypervascular blush. This is post-embolization, deposition of lipiodol in the tumor. So good deposition of lipiodol cast in the tumor. This is a pre-procedure CT showing tumor thrombus and the tumor. And this is post-procedure lipiodol deposition in the tumor. So this is a more or less ideal deposition in the tumor. So how TACE helps? TACE delivers chemotherapeutic agent directly into the liver with an angiographic route through the artery, because HCC is supplied majorly by the arterial system. And there are various types of transarterial chemoembolization, conventional and drug-eluting beads. So conventional embolization, major part of the drug goes in the liver, whereas in drug-eluting beads, 100% of the drug goes in the liver. So drug-eluting bead taste is better than conventional taste. This patient was injected with 100 milligram doxorubicin mixed with lipiodol and 100 milligram cisplatin. Microcatheter was super selective, so the advantage is super selective cannulation and super selective infusion of chemotherapeutic agent. Another case, we can see the arterial enhancing lesion in the right lobe of liver, segment 7 and 6. This is pre-TACE. Liver angiography, hypervascular blush of tumors are seen, and there are multiple lesions. You can see in the below image. And this is post. This is good deposition of lipiodol in the tumor. Similar case, right lobe large HCC. These are all patients with a palliative intent where the surgery is not feasible because of various reasons. And hypervascular blush is seen, and this was post-embolization. Indications of TACE, non-resectable HCC with or without segmental portal vein thrombosis, chemorefractory colorectal mets, neuroendocrine tumor, and intrahepatic when the tumor is enhancing, and intrahepatic cholangiocarcinoma. Sometimes we do TACE for them also. Contraindication is main portal vein thrombosis, decompensated liver disease, and when HCC is when there is more extrahepatic spread than the intra. Then 68-year-old male, diabetic, good GC, large right lobe HCC with all portal vein thrombosis, was on lenvatinib as a systemic therapy, but there was no extrahepatic disease on PET. So it was transarterial radioembolization was done, where we inject radiotherapeutic agent, yttrium-90, which emits beta rays into the tumor, specifically by the angiographic route. So you can see the portal vein thrombosis and the large HCC, more than 13 centimeters in size. This is a right hepatic artery angiogram and a super selective angiogram into the tumor. And this is the tear kit where the radioactive yttrium comes in with this kit, and we inject it super selectively into the tumor feeding artery. So this was the first case we did of Y90 injection into the tumor. Indications of tear, large HCC with portal vein thrombosis, neuroendocrine and chemorefractory colorectal mets. But most important thing is tear is the only modality where we can have atrophy of the tumor, size reduction of the tumor over a period of time. Another important case, this is a case of hilar cholangio. Plan was curative, intent was curative. So plan was right hepatectomy, but FLR was less. Future liver remnant was less in percentage. So a plan of right portal vein embolization was done. What do we achieve by right portal vein embolization? More of the portal vein flow goes in the left lobe. So the left lobe, the size becomes more over a period of 2 to 4 weeks. So this is very important in patients where there is curative intent. The first image shows a pointer is not working. Pointer no? First image shows a portal veinogram from the ipsilateral route. We have punctured the right portal vein from the ipsilateral route so that we don't damage the FLR. And there is already PTBD in place. The blue arrow shows the PTBD in the first image, A. And we have embolized completely the right portal vein and segment 4 branch. Segment 4 branch is embolized with coils and the right portal vein is embolized with glue. So what it achieves is most of the portal venous flow goes in the left lobe of liver. There is mild increase in the portal venous pressure due to the tumor, due to the hepatocyte HGF, hepatocyte generating factors, there is hyperplasia of the left lobe, and FLR becomes high. There is 5 to 10% increase in the FLR after 2 to 4 weeks. FLR, we should at least have 30 to 40% FLR, 30% in steatosis or post chemotherapy liver, and 40% in child age cirrhosis. Young female presented with hypotension with high beta HCG and hemoperitoneum. Ultrasound showed hemoperitoneum, so a CT angio was done. CT showed a choriocarcinoma taken up for the uterine artery embolization. So this is the pre-procedure iliac angiograms and superselective left and right uterine artery angiograms. We can see the tumor blush here. And this is post-embolization iliac angiograms showing no filling of the uterine artery. So this was a ruptured choriocarcinoma and taken for emergency stopping of bleed, and because there was severe hypotension and hemoperitoneum. GI bleeds we see at different levels. We see tumor bleeds, we see pseudoaneurysms. This is just an example of pseudoaneurysm in a pancreatitis, and this was a celiac gastroduodenal artery pseudoaneurysm. Gastroduodenal artery was filling from the SMA, and this is post-coiling. Very important role in GI bleed we have in non-variceal bleeds. In varices, the endoscopy management is first, whereas in tumor bleeds, embolization is generally preferred. Post-surgery for a bowel resection, small pseudoaneurysm, the red arrow in the ileal branch, presented with hematoma and hemoperitoneum, evacuated once, but pseudoaneurysm was not treated. So there was repeat bleed. And the white arrow shows the coiling of the pseudoaneurysm, and there was no further bleed. After GI, coming to the chest, this is a case of hemoptysis in a lung mass. CT showed a right upper lobe lung mass. Patient was on palliative management, had moderate hemoptysis. So this was bronchial artery angiogram, and we can see the large bronchial arteries and the intercostal arteries with arteriovenous fistula, bronchial artery to pulmonary vein. And this is post-embolization, where we don't see any hypervascular blush. We embolize with particles so that it goes up to the capillary levels and stop the bleeds. This is just to show how a bronchial artery pseudoaneurysm is seen. The blue arrow shows the pseudoaneurysm, and this was embolized. Diabetic hypertensive 55-year-old male diagnosed with left renal mass with mediastinal and lung mets. So in a renal tumor, palliative nephrectomy gives more survival benefit than a renal artery embolization. But when there are so many mets and we don't want to, a patient doesn't want to undergo a major surgery like palliative nephrectomy, we can do renal artery tumor embolization selectively. You can see the tumor blush. Blue arrow shows the blush, and this is a left renal artery angiogram. This is post-embolization. Rest of the arteries are patent. Only we have stopped the blood to the tumor. So there is tumor necrosis and some survival benefit. Also, this is also done in a metastatic patient where there is hematuria. Coming to the bone tumors, is a 40-year-old male presented with lower back pain. Radiograph, X-ray, MRI showed a large ischial giant cell tumor. Ischial giant cell tumor, best they are operated and resected, But in giant cell tumor, there is too much vascularity. So we do a pre-op embolization, and it helps in surgery and reduces vascularity. So this is angiogram of the left iliac artery, internal iliac, and then super selective cannulation of each and every tumor feeding branches are done, and they are embolized with particles. This is post-embolization. So patient underwent surgery the next day. Surgery is generally done 24 to 48 hours after embolization, so that if we delay the surgery, there is development of collaterals. So better to do surgery in the next day. Young female, 38 years, is a large chondrosarcoma, exophytic from the left iliac bone. Surgeon tried to operate, but they had to close because of the bleeding. Then referred for embolization. Again, super selective cannulation from the internal iliac, left internal iliac, and profunda femoris. There are too many vascular channels. And this is post-embolization. Then also the closure of the venous channels was done, because it was also needed, and with glue. So this is arterial and venous embolization from both the sides, and patient was operated the next day successfully. Giant cell tumor of the radius, distal radius. We can see the microcatheter in right side image, very distally in one of the branches of the radial artery. Embolization was done, and there was pain relief. Surprisingly, in the histopathological examination after resection, there was complete necrosis of the tumor. We embolized, but we never could achieve 100% embolization, but this is one of the rare cases. The finger branches are patent, so there is no complication. Large neurofibromatosis, head and neck, bleeding from the dressing site. So it was compressed with this was a neurofibromatosis, young male. There is pseudoaneurysm of the facial artery. And this is post-embolization with glue. We can see the glue cast on the right-sided image. So this is a palliative embolization. So coming to the head and neck malignancy bleeds, this type of patients are not poor. They were just gone for the homeopathic treatment and Ayurvedic treatments. So this is not common, but they are not poor, but they opt for the other treatments, and then they present with, after naturotherapy treatment of 3 to 6 months, they present with this kind of, and it is very difficult to stop this kind of bleeds. But we do an angio, and we occlude all the arteries going to the tumor and try to stop the bleed. 60-year male operated for head and neck malignancy post radiotherapy. Many times we see this type of cases. They are not uncommon. Post radiotherapy, post surgery, difficult to go in once again by the surgeon, and there is bleeding. There is a pseudoaneurysm from the common carotid bulb, and we place a covered stent graft. So in large arteries we cannot close. We have to place a stent graft. Graft is what? It has a covering outside the stent, and so it stops the seepage of blood and stops the bleeding. Post Whipple's, day 11, bleed from the drain. Generally post Whipple's bleeding is from...
Sir, 2 minutes left.
Yes. On 7th or 8th day, but this was bleeding on 11th day. CT showed a GDA stump bleed. Celiac hepatic angiogram, which shows a GDA stump bleed. You can also see a ERCP plastic stent inside, and also the NJ tube. This is post stent graft insertion, The blue arrow in the first image shows the bleed, and the last image, blue arrow shows the stent graft inserted. This was a coronary stent graft inserted in the hepatic artery to stop the bleed. This was a known case of soft tissue sarcoma thigh with METs, had left-sided chest pain. So a CT was done which showed a small aneurysm in the thoracic aorta. You can see the mass, lower lobar mass, and this is invading the aorta. This was a case of soft tissue sarcoma. So aortic stenting was done. This post-stenting, no filling of the aneurysm. SVC syndrome, lung mass obstructing the SVC. There is facial puffiness, very bad quality of life, and upper limb edema in this kind of patients. They are all palliative patients. So what we do is we open up the SVC, and the facial edema and upper limb edema gets resolved in 24 hours. So this is a very good procedure in palliative patients. We know that the survival is 3 to 6 months, but it gives a good quality of life. This is the SVC slow flow and multiple collaterals. And the right-sided image shows no collateral filling and opening of the SVC after stenting. Thank you.
Thank you, Dr. Rozil, for giving core knowledge on the topic of transarterial intervention in oncology and sharing good cases with us. Any questions from the audience? And comments and suggestions from the moderators are welcome.
Excellent presentation. I'd just like to know the follow-up of that patient which you had done where radioactive material yttrium-90 was injected. So did it regress enough to be able to undergo a surgical resection? And is there any limitation on the number of lesions that you can embolize at a single sitting in liver?
This patient was done 15-20 days back. This was our first case in Gujarat. Generally, with portal vein thrombosis, it is not a pre-op embolization or something. So it was just a palliative intent, not a curative intent. With a number of lesions, if the entire right lobe is involved, we inject the deuterium in the right hepatic artery. So it goes in all the lesions because the HCCs are vascular. So there is no limit to the number of lesions we treat. But in what we can do is we divide the dose. Right lobe we do, if we do the right lobe today, we do the left lobe after 3 months, if the lesions are on both the sides.
The reason of asking the question for multiple lesions is because now selective liver resection is coming up in a big way. So if there are multiple lesions, if you embolize, region decrease in size, then probably your FLI will increase to some extent and still patient can go multiple resection of the liver and preservation of a good amount of liver, rest of the liver.
Yes. This causes atrophy of the tumor, but it takes time, at least 6 months for the atrophy to occur.
So I'll just like to add to that comment. It's a very relevant question because the application of radioembolization as one of the application is to cause hypertrophy of the opposite liver. So it of course causes atrophy of the tumor as well as it causes the hypertrophy of the opposite liver. So it makes surgery more feasible. So one of the indications for radioembolization is to downstage it to surgery. So in such cases it definitely helps. But as rightly told by Rozil, because it was a vascular thrombus, tumor thrombus, it was not an upfront operable case. So essentially the indication was to palliate. So in such cases also, otherwise non-treated, such patients have a median survival of around 7 to 9 months. And with radioembolization in our data, it is around, the median survival is around 16 months.
Thank you, sir. Thank you for the very nice inputs. Any suggestions from the moderators? Okay.
Thank you.
Thank you. Sir, Dr. Rozil, please wait. I request Dr. Pragnesh Vagela, sir, for felicitating Dr. Rozil. Sir, please. Thank you, sir. Now moving to our second